It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
I wanted to thank everybody who's joining us for this webcast. Before we start with the webcast, I just have a few announcements. We do have ultrasound training coming up this March on the 8th in New York City, as well as May 17th in New York City. And we also do private training as well. If anyone is interested, just reach out to me after the show. In addition, we are happy to mention the great conferences coming up. ASPN in Miami, July 17th to the 20th. We have Pain Week in Las Vegas, September 2nd to the 5th. And the Latin American Pain Society, September 10th to the 13th, followed by NICIP and all the other great conferences coming up. Yaakov Kagan is the CEO of Big Leap Health, and they're doing amazing things. And I invited Yaakov, who, by the way, Big Leap Health is sponsoring this webcast, not Spravato. A little confusion there. And Yaakov, welcome to the show, and please tell us a little bit about yourself and your company and the great things you're doing.
Yeah, thanks so much for having me. Really appreciate it. I put together some slides that we can go over here. Let me see if this will work. Can you see my screen?
Perfect.
Amazing. So today we're going to be covering Spravato, or known as esketamine, and some of the opportunities and challenges that exist for pain doctors in the space. So just a little bit about me. I'll go over my background in a second, but just as a brief legal disclosure that all of this is for informational purposes. So I wouldn't interpret any of this as legal, medical, or financial advice. Definitely, do your own research on all of these things and use this as a purely informational session. So with that, just wanted to talk a little bit about me and our company. Hang on. I get this to work. Oh, here we go. There we go. So a little bit about me. I spent the first 7 years of my career working in technology businesses. I was an early employee at IBM's Watson Health team, which was like their AI healthcare team doing software strategy. And then I spent some time on the West Coast working as an early employee at what became Uber. And then I came back to New York and worked at several technology companies that exited to other public companies. And as I'm sure a lot of people have experienced, grinding away at startups for 5, 6, 7 years, I actually developed chronic pain myself. And it's also during the peak of COVID, we were just all spending a ton of time at home. And a friend of mine who is an MD, PhD neurologist and neuroscientist reached out to me about helping him start a telehealth pain management business. Now, at the time, I knew nothing about pain management or healthcare, candidly, but I was really passionate about it, just given my own personal experience in chronic pain. And so today we actually operate across 11 different states with more than 60 different insurance companies. We're a completely opioid-free practice. And one thing that I experienced as, our team, we're seeing all of these patients, was how common, when we'll talk about this a little bit more later, but how common depression and anxiety was, how commonly it was comorbid with chronic pain. But being a telehealth practice, there wasn't much we could do from an interventional perspective to provide, this kind of care to patients. And then at the same time, I actually went through my own interventional psychiatry and mental health journey myself. And at the time, none of this was covered by insurance. It was extremely expensive. It was heavily stigmatized, and there was no technology or service enablement for any of this. It was an incredibly, pun intended, painful experience. So I spent quite a bit of time just based on my own lived experience, my practice's lived experience, just meeting with other clinicians, meeting with patients, just to better understand, why is this so, why is this so painful to do? And that's what kind of led us to start the company Big Leap Health, to really work with practices that are interested in launching and growing successful, profitable Spravato and TMS programs, essentially. So I know that was a long-winded answer to your question, David, but hopefully that answered it.
Nice.
Cool. So just to move on here a little, I just want to talk briefly about what is esketamine. I think that we're all probably a little bit more familiar with ketamine, which is a cousin of esketamine, but very similar in nature, with a few really, really important key distinctions. Esketamine is actually FDA approved to treat depression and suicidal ideation. It's typically administered via nasal spray that's under the supervision of a healthcare provider. So typically what that means is that you'll have a prescriber physically present in the office while you have a healthcare provider of some kind who's basically overseeing the patient. And we've seen a lot of different permutations of this. We've seen situations with cameras, for example, where you put a camera in the room and then you've got a bunch of TV monitors and then you've got someone watching all of these monitors, for vitals, blood pressure, and so on, just to make sure that the patient is okay over the, 1 or 2 hour period that the care happens. The side effects are very common, very similar to regular ketamine. You get mild nausea, dizziness, and headache, which makes a ton of sense considering this is a dissociative drug. And it's
What
also
about the risk of a bad trip? Is that something that they see?
no, because it's very carefully dosaged. There are only 2 approved dosages of esketamine, 56 milligram and 84 milligram. And so as a result, I would say that any dissociative treatment can have I wouldn't call them bad trips. What I would say is that unlike an SSRI, this kind of really gets at the root cause, a lot of the time at the root cause of your mental health challenge. And that can be uncomfortable for patients to manage through. However, I will say that, and we'll get to the clinical evidence in a second, all of the clinical evidence was done in the absence of therapy, and it's actually indicated for treatment-resistant depression and suicidal ideation, even with the absence of therapy. It's actually been shown to be efficacious. So, look, I think while not a medical side effect in a bad trip, that's definitely something that's certainly possible.
So to institute this, I'm sorry to interrupt you. I hope you don't mind.
No.
To institute this in the clinic, you need a psychiatrist labeling the patient as major depressive disorder, or
no,
you just say, hey, you're depressed, let's try this, or do you need a psychologist? Like, what
That's a great
criteria to select for patients?
Yeah, that's a great question. So you don't need a psychologist or a psychiatrist to do this. Any doctor who has a basic medical training is trained to diagnose depression. What I will say, and that's the FDA indication, what I will say is that certain insurance companies, whether it's, you could believe it's because they want to limit access to care or because they believe it's clinically efficacious, will require you to either to consult with a psychiatrist. Now we're also seeing different provider types being accepted as well, like behavioral nurse practitioners can also be consulted with. And then other insurance companies will require that a psychiatrist or a behavioral nurse professional, like a provider, does the prescribing. Now it can still be supervised by a healthcare provider, and it doesn't have to be that same psychiatrist or behavioral nurse provider who's physically on site doing it. It just has to be prescribed by them. So one thing we do see sometimes is you have what's called like a Spravato treatment center, where basically a psychiatrist who's not even associated with the practice has prescribed the Spravato and said, hey, your nearest Spravato treatment center, or we have a relationship with XYZ practice, you should go there to get your Spravato.
So what does the practice need I'm sorry to interrupt, but what does the practice need to have to be a center, a crash cart, AED? Like what exactly?
Yeah, so a bunch of things, which we can unpack. But first, you need a DEA license. You need your DEA license to be associated with your practice. You have to go through a compliance process as well, called a risk evaluation and mitigation strategy, where you basically agree to follow a certain set of protocols and principles, mostly around a few things. One, that you'll report to Johnson & Johnson and their affiliate every single time you administer the drug. A few key questions, was this person, did they experience sedation? Did they come in, did they experience symptoms of various, bipolar disorders, or did they have there's a whole litany of things Did you observe that they have taken new medications that you weren't aware of previously? And so on and so on. There's about 25 questions or so, mostly yes or no, that are asked through this risk evaluation and mitigation strategy. Another piece here is that you'll need like a physical safe to store the Spravato drug. One of two things will happen. You're either basically giving the drug, you're buying and giving the drug to the patient yourself, in which case you need to store it in the safe, or you've done it through a pharmacy benefit, in which case the pharmacy has mailed you the drug, and you'll have a specific lot number that's associated with that drug and associated with that patient. And that's done for a lot of reasons. Some of the bigger ones is that we definitely do not want patients taking the Spravato drug home with them. And we want to make sure that we're tracking every single box of Spravato as well. So from a clinic's perspective, that's, I would say, a piece of it. That's like a piece of the compliance. Then there's like a lot more to do with billing as well. There's prior authorizations you have to do. There's selecting whether or not you're actually giving the drug that you've bought to the patient versus from the pharmacy benefit. And there's a bunch more that we can unpack. So what I would say is that any clinic can actually be an administrator of Spravato, provided they've got the infrastructure set up to be successful. Again,
So
I think a long-winded answer there.
yeah, I get it. No, because I understand why you target pain practices because they're ideal. We have the infrastructure set up. We have, at least my office has quad A room with all the equipment, the lockbox, everything. So it makes a lot of sense. And now that we're talking, I'm thinking about I have a patient who is in such pain and so depressed. And every time I'm telling him you need to see a therapist, he's telling me he can't afford the private psychiatrist or psychologist. Somebody in my office speaks his native tongue, but he can't find someone who speaks his native tongue that could treat him. So there's so many barriers to good psychiatric care. So I do see a utility for this. I guess the idea is it's just a new drug and the whole authorization process and billing and monitoring. So are doctors monitoring like 10 patients at once? Can you do that? Is that legal?
Yeah, so typically, a few things there. This is a little bit of a gray area. There's no definition of like how many patients are too many to monitor at one time.
Okay.
And then the other piece is, again, you don't need the doctor to be monitoring all these patients as well. Typically, what we see is that you get one-to-one. There's three factors to consider: space, I guess four: space, staff, operational and compliance wherewithal, and then and patience, basically. So you need the combination of all of those things. And I say that because you have to be monitoring this patient for at least around 2 hours. And so if you have like one room in your private practice, that's going to constrain you depending on, unless it's like a really big room. If it's like a small room, you're going to be constrained in that way, because you do need space to make sure that these patients they have space to be monitored. Typically, sometimes what we see is for the first 15 minutes, they're in like a private room. And then afterwards, they're kind of led to a semi-private room with other patients where, they can be monitored. And I think it also comes down to patient experience, right? Like, do you give the patients headphones to listen to and a blindfold to kind of, be more in the disassociative state? I think that's at the discretion of the clinic and the practice and the doctor.
Okay, a few questions logistically. Are you increasing the dose as time goes on, or are you keeping the same, or?
Yeah, so there are two dosages, 56 and 84 milligram. What I would say is that we see about 70% of patients doing the 84 milligram and 30% of patients doing the 56 milligram, maybe even sometimes 80-20. Typically, you'll start them off on this lower dosage. The sprays come in 20, I think you can even see it in the picture here. They come in 28 milligram sprays. And so typically you'll start them off over their first few sessions on the 56 milligram. And then if they tolerate it and in your clinical judgment, you think it's appropriate, you can increase them to the 84 milligram. And this is very structured, intentionally so, because that's what the clinical evidence suggests is efficacious.
And they recommend one spray, 28 milligrams, or two sprays. Like you're not like doing like a nasal cortical steroid.
It's 2 pumps in each nostril. First of all, there's like a 5-minute pause. There's 2 pumps in each nostril, and then a 5-minute pause. And then you're switching. Each of these is 28 milligrams, so you would do that twice over a 15-minute time frame.
And are you pre-medicating with a midazolam or anything to blunt or any sort of, adverse effects of the
I
disease?
think that I have not seen that. I think that's at the judgment of
Zofran or ondansetron for nausea or glycopyrrolate for secretions that you could possibly
I
do.
I haven't seen that. I have seen that after after the patient is on the Spravato, that sometimes if they have high blood pressure or
Okay.
nausea or something like that, at that point you can give them some medication. Not so much beforehand, just because of the limited side effect profile.
Okay, so you have a lot of doctors listening to this. So I guess one of the things we need to know is what's the worst that can happen?
Yeah.
I mean, we know if most of us are pain doctors, so we know what ketamine does. We know what the worst with ketamine is.
Yeah.
I
So
guess, uh, you know, are there any stories or anything? I mean, like,
I have not heard of any instance, and I've talked to a lot of providers about this. I
right,
don't think I've ever heard of an instance of someone being hospitalized ever, actually, ever, which is saying something. I think there have been a few instances where, we had to, a clinic had to like move the patient to a different room to get some more air or something like that. Um, I would say that this is not indicated for like bipolar or psychotic patients. And so there's some patient screening that has to happen to make sure
oh,
that
yeah,
these are not like high acuity cases to monitor for that. And then I would also say you're monitoring vitals at the same time. And so in the first 15 minutes in in the incubation period or whatnot, if you start seeing the blood pressure spiking, then obviously I would not, increase the dosage. But I would
right.
say the most common side effects are headache and dizziness. They're very mild. These are very mild side effects. We're not talking about like 200 milligrams or something of ketamine. These are
Sure.
fairly mild to moderate dosages. Um, there are a few contraindications. I don't know if I have it in this deck, and I don't remember if I remember all the contraindications off the top of my head. There's 3 or 4 contraindications that you have to screen for, but those are all very uncommon. I think in all the practices I've worked with, I think there's been like maybe 10 patients total that have had a contraindication.
I mean, I'm going to guess what they are, but I don't know for sure. So probably uncontrolled hypertension,
But
increased intracranial pressure,
yes, yes.
or ruptured orbit, with the eye,
There's
cycle
there Yeah,
or
we do actually every practice we work with, it's aneurysmal vascular disease, one of them. I'm
sure.
trying to remember all 4. There's
Aortic aneurysm.
yeah.
Uh,
Trying to remember the other. There was a couple more. There's arteriosus malformation, something like that.
AVM.
Yes, and then I'm missing one that I don't remember off the top of my head. Um, Maybe some sort of peripheral arterial vessel issues, something like that. Like anything, yeah, I would say if you have a history of hemorrhage, like cerebral hemorrhages, that's also counterindicated. Those would be the main ones I would say. Like if you've had a brain hemorrhage, I would avoid esketamine.
Gotcha. So,
But
what types of questions, like if I'm thinking about integrating this, what should I ask myself before I launch it?
yeah, I think I had a slide on this somewhere. Let me see if I can pull it up. Um, I had a good
I
slide
mean,
on
the
this.
first question after is it safe? Does it work? And am I going to get paid?
Yeah.
Those are
Yes.
the questions. That's the order.
So the first question, one thing we see with pain practices is depression and anxiety are very, and that's what I've experienced in our practice. Depression was the number one comorbidity associated with. So the first question I would ask myself is, do I have a lot of depressed patients? And if it's anything like our practice, we have a lot of depressed patients. So that would be question number one. And then I would say question number two is, do I have the space for this? I would say is important. Like I said before, space is often a limiting factor. And then three, do I have the operational and administrative capacity to do this basically? There's a lot of complexity when it comes to compliance, and then the billing has a lot of its own nuances and whatnot. So that would be a question I would have. Um, and then, yeah, I would say those. And then I guess the last one would be, do I actually want to focus on growing my practice? I was talking to a couple of pain doctors today who basically said, we're good where we're at. We actually don't want to grow the practice. And so if that's who you are, then yeah, this is a new program and a new series of treatments. And so if you want to just take it easy, probably not the right fit.
Well, a lot of us are young and hungry, so I could see why a lot of people would do it. Um, so I guess like what other resources aside would doctors be interested in to find out more?
Yeah, so I guess I can skip ahead here. Just a
Oh,
couple
you
things.
could go in order. I just had some questions, but go ahead.
Yeah,
Good
yeah, yeah. I would just
order
note
and we get to
a
them
couple
later.
of things I just want to highlight that might be of interest is that this is actually becoming way more popular in the last couple of years. Johnson and Johnson, who is the developer of the drug, just had their annual financial report released today, and what they're seeing is that Spravato has more than actually since this is done more than tripled in popularity in terms of prescriptions and interest in the
Wow.
last couple of years. There's more than 50,000 prescriptions now of this on a monthly basis, and it's growing about 50% year over year as well. And the other thing I would just note is we work with a lot of different insurance companies. I can't name a single one that does not cover esketamine and Spravato in some way. And we even saw, a Wall Street Journal article a few months ago talking about how it's taking off. Yesterday, the FDA, and we'll talk about this, the FDA just expanded the indication for the drug, which we'll talk about as a monotherapy. And then last month, the American Journal of Psychiatry had a whole issue just dedicated to psychedelics and Spravato and whatnot. So
Amazing.
this has really picked up momentum in the last, I would
So they're
say,
gonna stop paying for pain management. They're gonna start paying for depression treatments in our office. That's amazing.
well, they'll do both because it's a comorbidity.
Yeah, but it's been a tough year. They're trying to cut back on so many things and not pay for so many
We have seen
valid
that.
proven therapies.
That's true. And so when we talk, I know you asked me like, how much does this actually make? So when you think about it, there's basically a couple nuances taken into account. What state you're in, whether or not you're both buying and billing the drug versus just administering it. I would say that, and also for how long is the patient being seen? I would say on average, you can expect somewhere around $10,000 per patient over a period of a few months of care. And that again really depends a lot on the state, the insurance, this is a Medicaid plan, a Medicare plan, commercial whether and so on.
Okay.
So I guess to your question, it's like, I'm interested, how do I get started? I would just recap a little bit first of like, what is Spravato? It's an esketamine. It's very similar to ketamine as you know it. I would say it has a very low side effect profile, especially compared to SSRIs. I think we're all very familiar with all the side effects, weight loss, low interest, reduce emotional sensitivity and so on. So a couple things. These are kind of the questions you were hinting at that I just want to touch on. How much is this going to cost? What are the augmenting therapy requirements? Who can be prescribing? What are the clinical supervision requirements and more? And there's quite a bit of those. I think we touched on some of them, but these are kinds of the typical questions we get a lot. Just want to touch on like, I know we kind of danced on like, how does a patient go from like, hey, I'm interested in this to getting over the finish line? I think we're all pretty familiar with concepts like intake screeners and whatnot. I think I touched a little bit on that initial clinical consultation where these options are discussed, the administrative elements of figuring out, hey, are there different discount programs that this patient can qualify for, figuring out whether or not you're buying the drug and billing the drug, sending all those compliance forms to Johnson and Johnson saying, hey, here's what we did today. Obviously billing for the treatments, and so on. So there is a significant administrative burden associated with this care, just because, this is a controlled substance. I think we touched on this, but there are a bunch of subsidy programs associated with Spravato to bring down the cost, both by the drug developer and Johnson, and then various state and federal programs that can further subsidize the cost of the treatment. I think I had an example here of a pain practice that actually expanded into this. And so this is Hudson Mind, which used to be called Hudson Health or Hudson Pain, and then expanded into Hudson Health and now Hudson Mind.
Wow.
Integrating Spravato into my practice has been a win-win. Patients benefit from rapid and meaningful relief from depression, and our clinic consistently receives strong reimbursements, enabling us to expand access to this vital treatment. I think that probably at least a third of their practice now focuses exclusively on behavioral health, just given the opportunity.
That's a big pivot.
Well,
That's
it's not a pivot so much. They're still doing all of that pain.
right.
They've expanded into behavioral health. So it's not that it's been additive, you know?
Right, and it makes sense. I mean, it's pain is partially a psychiatric condition, I think. I mean, it's connected. It's all neurological, psychiatric, it's all connected.
You know, my business partner at our practice says it's all about the mind-body connection, you know, and I think that's this speaks to it, you know.
Absolutely.
So I guess we've kind of summarized this, so we don't need to harp on this, but you know, patients are usually already interested in accessing this. There's been a big uptick in interest just generally. This is really indicated for treatment-resistant depression. It's well reimbursed. There are different financial reimbursement programs, and there's, you know, like with any treatment, sometimes there's administrative complexity associated with it.
Yeah.
Cool. So I think that was kind of the presentation. I guess the thing I haven't answered probably, which was implied, is like, what does our company do, and how do we help with this? And I think if I just had to summarize it, we help practices launch and grow these kinds of treatment programs just based on honestly my own lived experience and then all of our experience doing this already. Our company exclusively focuses on interventional psychiatric treatments just because, frankly, it just requires a lot of niche and domain-specific knowledge. And because we work so closely with practices, we don't need to have an arm's length relationship like the drug developer themselves has as a, you know, a pharmaceutical company.
That's great. Just quickly, so you guys do this, and I know we're focusing on ketamine today, but how does Spravato compare to the TMS in terms of efficacy, time, and reimbursement?
Yeah, so I think we can first just talk about like how does Spravato work, and primarily it targets the NMDA receptors in the brain, which regulates glutamate levels. When you think about TMS, it's really a machine that uses magnets to target certain parts of your brain that are responsible for depression. So it's a different treatment mechanism. I would say that I think we skimmed over the clinical evidence here. In terms of efficacy, what I would say is that partially because Spravato, literally, you feel that you're on Spravato, there's a dissociative effect. That's my own personal opinion that makes an impact. But what the clinical evidence says is that patients see a meaningful decline in their depression within 24 hours of treatment. And then they see a statistically significant decline when looking longitudinally over a period of 3, 4, 5 months, or even up to 5 years.
Amazing.
When you think about TMS, I would say that you don't get as much of an impact immediately upfront, and I think you get comparable efficacy over time. I think what we've seen that's a little tougher with TMS is because you don't get that. This is more anecdotal. Because you don't see that immediate like improvement in your depression, patients are just a little bit less likely to stay around for the rest of the treatment, just because you have to come in. This kind of brings us to the time part where with Spravato, you're coming in twice a week for the first month and then once a week for a couple of months after for 2 hours at a time. With TMS, you have to, at least for the FDA indicated version of TMS, that's covered by insurance, you have to come in 5 days a week for months at a time. And so that's a massive time commitment for patients, whereas with Spravato, it isn't. And so it just makes it a little bit easier to manage. And then I would say the other piece on Spravato is this is a positive experience, you know, like it is pleasant to be taking Spravato, whereas with TMS, I would definitely not say it's unpleasant, but I can't say that it's like a joyful experience. In terms of reimbursement, I will say that it really varies again by payer, whether or not you're buying and billing the drug. I would say that if you are buying and billing the drug and you're in a favorable state, Spravato will definitely reimburse more. I would say that, you know, I think I had it on the slide here. You can expect somewhere around $10,000 per patient, whereas with TMS, you probably can expect something closer to between 4,000 to 8,000, depending on, you know, your specific payer, patient, state, provider mix.
Those numbers are pretty impressive. I think I guess, you know, I really have to do it to see the work involved to see how impressive it is. But I mean, imagine doing 50 patients, $10,000 each. That's like $500,000.
Yeah, I think
I mean, I understand the reimbursement changes from place to place, and it may not exactly be $10,000. It could be 2 grand for some, 12 grand for others, but either way, I have a comment here from someone who's listening who tuned in late. He's interested in opening up an infusion center, but also offering Spravato. He wants more information, and he came in later on. So you guys, we're recording this. It's going to be available on the Pain Exam YouTube channel, and you have this is a QR code on the screen, right? So they can scan that and get your contact to follow up with you guys.
Right. And by the way, we also work with practices that want to offer TMS as well. There are different, but they're similar and different requirements and rules and things to be mindful of when it comes to TMS. And then we actually also work with even with practices that want to become, start offering ketamine infusions and helping to even complement those services with these FDA-approved insurance-based treatment modalities. We might do another session on TMS if there's interest as well.
Yeah, I think this is great because of us pain doctors. We're too busy to like do the work that you guys are doing, and even our staff are stressed and they got so much going on fighting with insurance. So it's sad that we need a service like yours, but we kind of do. So thank you. I really think this is great, helpful, and I imagine we're going to see a lot more of this in the future.
Thanks for having us. Yeah, I was talking to one of the partner clinics we work with, and what they tell patients now is like, don't worry, we've got an army of people that are fighting with your insurance company to get this approved. I don't think it's exactly like that. I don't think of it that way exactly, but I do think equipping practices with celebrating practices and equipping them with the tools and resources to successfully get these treatments to patients is really critical.
Exactly. I think we have one more question or comment before we wrap it up, and it's from actually we have a couple, it looks like. So the first is locally for New York, what's the range of reimbursement? Health First and other Medicaid plans, are they covering the drug?
Yes, Health First, Medicaid, almost every Medicaid plan I've looked at covers it. We actually happen to work with several pain practices in New York, and it is covered by Health First, and it's covered by Medicaid. And then in terms of reimbursement, I guess there's like a broader question of like, what does the New York market look like? And then I think there's like a Health First Medicaid specific question. In terms of the broader market in New York, I would say you can expect, somewhere around a third of patients to have an insurance plan that supports buy and bill, which, again, dramatically increases your potential reimbursement. So I would say that 10,000 figure is about right for those kinds of circumstances. I would say that with Medicaid, you should expect like a 20% discount relative to what you can expect from like a commercial or Medicare plan.
So if you're not doing buy and bill, that 10K number goes down to what?
Depends on the state, but I would say somewhere around six to 7,000, I would say, or closer to 6. And then if you factor in the Medicaid piece, then you're looking at like 5 to 6.
I
In New
see.
York.
Sorry, go on.
I was just saying in New York, that's just New York specific numbers.
Got it.
Also, just if you're curious, I'm also happy to have a conversation. Whoever asked this question, I'm happy to have a conversation with them to dig into the numbers a little bit more.
And they are this. I think the same person is anonymous. They asked how your company got. How does your company get compensated? Is there a fee that the practice pays to Big Leap?
Yeah, so there's typically 2 or 3 costs. The first one's an onboarding fee. We invest a lot of time and energy in every partner that we work with. There's a pretty steep learning curve where we train you both from a clinical perspective, from an operational perspective, and from almost like a patient intake perspective. And that's a big commitment on our end. So there's like a one-time, it's not like a ludicrous amount of money. It just really to have someone put it like having skin in the game, I guess, that you're committed to doing this. And then we basically charge a flat fee depending on what state you're in. It can vary by a lot of factors, but essentially we charge a flat fee for every treatment that happens.
Wonderful. Is there anything else you have to add before we wrap it up?
No, I think that it's been wonderful. I guess I can take this off screen share. It's been wonderful chatting. I'm really excited. And hopefully this was helpful and informative about the opportunity to provide, breakthrough mental health treatments to patients in need and pain practices.
Well, I want to thank Yakov of Big Leap Health for coming onto the podcast. And I appreciate you guys coming, spending this evening with us. Stay tuned for more. check out the pain exam website or the NRAP Academy, where we have more courses, webinars, lectures, etc., and board prep. Thank you, and have a great day.
Dr.
Thanks,
Rosenblum is here solely
Be
to
well.
educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.